So let me start with a statement that might have been considered very bold and even very blasphemous till about a decade ago. The fact that cancer is a genetic disease. And why do I say that? I say that because cancer, we know that it is characterized by high heterogeneity, but more than that, there is now ample data to support that most of the very well-known characteristics of cancer, be it of dysregulation of growth or drug resistance or metastasis, we now have proof that they are caused by specific genetic mutations. And we know about these in very many cases. So let me start off. It said that the proof of the pudding is in the eating. So I'll start off first with the case studies. And this is the story of a 53-year-old gentleman and who was suffering from a loss of appetite, abdominal pain, nausea, fatigue, etc. And of course, the first culprit that one thinks of in this setting is liver and biliary disorders, which were ruled out in this case. And further investigation revealed that he had a very high serum concentration of CA19.9, which pointed towards a malignancy. So an ultrasound-guided CT and a biopsy was done, and he was confirmed to be suffering from metastatic pancreatic duct adenocarcinoma. And so the patient was, of course, counseled for chemotherapy, and the clinician also informed him about the availability of targeted therapy, which would require a biomarker genotyping test to be done. So the patient was counseled to undergo an NGS test. And these are the results that we have. We were able to identify the presence of EGFR L858 arginine, which is a point mutation, which is an activating point mutation present in exon 21. And the presence of this mutation means that the patient could be stratified to receive erlotinib and gemset combination, which was done, and the patient responded. The second case that I have is of a 67-year-old lady, a non-smoker, diagnosed as non-small cell adenocarcinoma on a lung biopsy on histopathology. And she was diagnosed to have EGFR L858 mutation by ARMS PCR. At that point of time, the NGS was not done, and ARMS PCR was done, and she was known to have this mutation, and she was put onto EGFR TKI. But what further happened was that she responded for about 7 odd months, and then she progressed. She showed progressive disease. She showed the presence of newer lesions. So a re-biopsy was done on the new lesion and sent for NGS. I'm emphasizing on this point, and I would take this up later. The results that we had, it showed that the earlier mutation that was detected on ARMS PCR was still present. However, we also saw the presence of a newer mutation which had not been seen on ARMS PCR, and this was the T790M mutation, which we all know that it is a mutation which is responsible for making the patient non-responsive, for making the patient resistant to EGFR TKI. However, lucky for the patient that by the time that this test was done, osimertinib was already available in India, and the patient could be stratified to receive this treatment. Now, the point that I'd mentioned earlier, that the biopsy was done, a fresh biopsy was done on the newer lesion. Now, why is that important? What the guidelines say is that if there is any patient who is being investigated for a tumor, for oncology diagnostic workup, of course, we go by what is the easiest. So the most accessible site is taken up. However, in case there are multiple sites, in case the patient presents with metastatic diseases, wherever possible, a biopsy should actually be done from more than one site. Better still, if there is availability of cell-free DNA testing, then perhaps that might be a better technique to use, whether on ddPCR or NGS, because that is a better representative of the genotype from all the lesions. However, in this particular case, what was done was a rebiopsy was done, and the testing was performed on that. Of course, we do know the scenario that in case upfront, if a liquid biopsy is done and there one does not identify any genetic driver, then there is still always the possibility that had one had access to a tissue biopsy, maybe there could have been some genetic driver that one might have been able to identify. So wherever possible, if a tissue biopsy can be done as a rebiopsy, go ahead with that. If that is not possible, then of course, if it is not feasible or the patient refuses, then liquid biopsy is one of the alternates that is available. The third case, another female patient who is an ex-smoker. She had a lung adenocarcinoma and she was treated with a platinum-based therapy because there were no driver mutations that could be identified at that point of time. After 2 years, she presented with pleural effusion. So a cell block, and the patient refused for a rebiopsy from the lesion that was present. And since pleural effusion was there, a cell block was made out of that, and it reconfirmed the presence that it was a lung adenocarcinoma. And the sample was sent for molecular analysis. In this case, we were able to identify a KRAS mutation. Now, traditionally, till about a couple of years ago, KRAS mutation only meant that the patient would have a poor prognosis. It was not associated with any drug response or any patient stratification for any specific treatment. However, now we do have an FDA-approved drug, sotorasib, which is specific only for the G12C mutation. All your other KRAS mutations still get categorized in lung cancer, still get categorized as only a prognosticating factor and not associated with drug treatment, except for G12C, which we were able to identify in this particular patient. The fourth case, this time a 43-year-old male patient, and he was a heavy smoker with persistent cough for 3 months. In India, invariably, as a workup, one of the first things that needs to get ruled out in a case of persistent cough is tuberculosis, which was done in this case. The patient was negative for tuberculosis, and a lesion was identified on CT. Upon biopsy, it turned out to be non-small cell adenocarcinoma, and the doctor decided to go ahead with only a short panel testing. In this particular case, it was only the most important, the predominant genetic driver mutations for non-small cell lung cancer, which were tested. And the patient was negative for EGFR, BRAF, ALK, ROS, PD-L1. They were all negative. The patient was at that point of time advised to go ahead with extended NGS panel along with TMB. And what we had was that there was still no relevant genetic driver mutations that we could identify, but the TMB score in this case was high. As you would know, that a TMB score of more than 10 mutations per MB is considered significant and high. And in this case, it was about 12.8. So what this meant was that the patient could be stratified for immunotherapy. Now, this is kind of in contrast to what you have here. Typically, most of the time, what is done is only PD-L1 testing. And if that is positive, then the patient gets stratified for immunotherapy. In this case, PD-L1 was negative. However, TMB was positive. Now, TMB in itself, over the last few years, about in the last 5 to 7 years, there's been a lot of controversy surrounding it, whether it really has significance, importance enough to, stratify the patient to receive immunotherapy just basis that. And I would just want to quote this very interesting paper, which came a couple of years ago. And it showed in very, very clear terms that there are certain cancers, certain solid tumors in which a TMB score does carry significance. And so TMB score is predictive of response in melanoma, colon, lung, and bladder cancer. However, a high TMB score may or may not be predictive of response to immunotherapy in breast or prostate cancer. So in this case, since we were dealing with a case of non-small cell lung cancer, having a high TMB score meant that the patient could be stratified for immunotherapy and would respond. My next case is of a 38-year-old lady, premenopausal, and who was diagnosed as metastatic breast cancer. She was ER, PR, and HER2 negative, so triple negative, also PD-L1 negative. And we received the sample at the lab for germline BRCA testing. So why germline? Because as per guidelines, we know that if there is a situation of an early onset breast cancer, or if it is a case of a family, if there is a strong family history of breast cancer, or if one identifies a triple negative at young age, in this case, she was a premenopausal woman, though the guidelines suggest anyone under 60 with a triple negative should be worked up for BRCA testing. So we went ahead, we carried out BRCA 1 and 2 mutation testing on NGS, and we identified a missense mutation in the BRCA2 gene, which as per ClinVar was a pathogenic mutation. And in terms of patient management, what this meant for this patient was that she could be stratified to receive olaparib, and which is, as we all know, a PARP inhibitor. So this is how the patient could be helped. So, and this is a point which has been mentioned earlier. If there is a case that any of you are investigating for BRCA testing, if there is a strong family history and on BRCA 1 and 2, it turns out negative, please ensure that MLPA is carried out before one calls it a clear negative. If required, an HRR assay ought to be done. So biomarker testing from a laboratory perspective turns out to be quite challenging in very many situations. There are times, especially so in cases of lung cancer or any other solid tumor, when the initial diagnosis has been made on a CT-guided biopsy. There is limited sample volume that we start with. And if there are multiple biomarkers that need to be tested, taking a reflex testing mode exhausts out the tissue very fast. And there are growing number of biomarkers for most indications. So there is clearly an unmet need of how to perform biomarker testing in patients in which either a biopsy is not available at all, or wherein the tissue sample got exhausted. So the options that we have is either we increase the scope of the technologies, which is really what we are doing when we use NGS over either a Sanger sequencing on a gene-to-gene basis, or ARMS PCR, or even digital droplet PCR, where we are only able to look at a limited number of genes. One could use microarray as and when required, or proprietary algorithms. The other option that one has is to increase the scope of the samples that we are using. The tissue sample, of course, remains the most important sample so far as solid tumors are concerned. But then again, if it is not available, if it was exhausted during the testing, then one can do testings in a limited manner on FNA samples or the cytology. One can use CTC or ctDNA, which Dr. Moshmi would be later talking about. And in our lab, we use the S5 plus, which is associated with the Iron Chef, and we use that automated platform. By and large, most of the panels that we are using for oncology workup are the Oncomine panels. And as Dr. Neeraj has already elaborated, that there is a wide spectrum of panels available to us. Some of them are these smaller limited panels, and then you have the 161 gene panel and 500 plus gene panel. What is though very, very important is that any laboratory which does NGS testing, which offers these tests, before these tests get offered for clinical use, they must undergo a very, very thorough analytical as well as clinical validation. And preferably using a matrix which is matched. So in this case, what we use for solid tumors, more than 98% of the time, are the FFPE samples. So using a representation of that. So in our lab, what we do is that we use annotated samples from Horizon Discovery or Actomatics. And it is humanly not possible to do a validation for every mutation that one might encounter, because frankly, one doesn't know what one might encounter. So in a limited manner, at least what should be done is to check for different kinds of mutations. So while one is going about the analytical validation, include in your include in your protocol samples which have clearly defined, and that is percentage-wise, clearly defined mutations which are SNPs, which are single point mutations, which are copy number mutations. It should include fusions, it should include insertions and deletions. Again, in our lab, since we have ARMS PCR, we have Sangers, we also use those samples, and that forms a part of the clinical validation that we use. So intertechnology, ECAS, and interlaboratory testing is what we use for our clinical validation. And this is what I've mentioned, that Thermo Fisher offers various different kinds of panels. Some of these are tumor-specific panels with specific number of genes, typically 15 to 25 or 30 genes. Important here that it requires really low sample input. So even with the probably limited, almost degraded DNA that one might get out of FFPE samples, it is possible to go ahead and perform these testings. Then the 161 gene panel, which has already been mentioned and commented upon in the earlier talks, very, very important, covers by and large most of the most useful hotspot mutations, which find a mention in the FDA ASCO protocols, which have drug associations, then specific copy number variations, and fusion genes, and the 500 plus gene panel. And there was a comment in one of the earlier talks that this would be quite expensive. Yes, it is quite expensive even for the labs that run it. But I would just want to sort of draw a small comparison with the other large panel, which again gets used quite often, and that is the Foundation One. If one compares the pricing of this Thermo panel with Foundation 1, this to the lab which is running it, it would cost about something like between 1/3 to 1/4. So is it expensive? Yes, it is. Is it as expensive in comparison? No, it does give value for money. However, the utility of these large panels from an Indian perspective, I would say, still remains rather limited. And the reason is not that we don't get to identify variants. We do. In each of these runs, we do identify variants, and many of them have clinical value also. But by and large, most of those would have meaning if there were more clinical trials, if there were more phase 1 or phase 2 clinical trials being run in India, because sometimes we identify variants for which there are trials running in US or Europe, but not ongoing in India. But I guess any patient who can afford to pay about $1 lakh for running this test might be able to go out and get treatment aboard. So briefly again, the NGS workflow for cancer testing. This is one of the really most important points. Our starting material is FFPE. Our starting material are the slides. Very important to at least do a macro dissection in association with the histopathologist, because just omitting this step itself might mean that one may actually end up missing out on variant calling of a mutation, which is actually significant. So most important step, I would say, always do at least a macro dissection of the tumor enriched area. Then, of course, the QC of the sample after extraction, as well as the quality control of library. There are times that this may just marginally pass, but sometimes the QC of the library itself fails. So go back, re-extract, rerun the test, rather than going ahead and completing the assay. Of course, then, like Toril has already spoken enough about how exactly the data interpretation is done, but from just an overview perspective, what is it that we are trying to do? We are trying to answer the question that which mutations are likely to be driver mutations, which mutations are likely to have an impact on helping the clinician manage the patient. Are the driver mutations pointing to an actionable target or not? So, yeah, so at least a QC ought to be done at these 3 points. After your sample isolation, after your nucleic acid isolation, after library construction, and at the time of data analysis. So most important really, in solid tumor NGS, the most important factor still remains the quality of the tissue, the quality of the FFPE block that we get. And these pre-analytical variables, they cannot be emphasized upon enough. So always use neutral buffered formalin. I mean, not fair to take names, and I wouldn't do it, but we often face, being a referral lab, we face this situation that there are specific places and specific centers from which we by and large know that the quality of sample that might come in is not really going to be all that good. In that case, we try and we, like, talk to the pathologist there, emphasizing to them that the quality of the block that is being prepared may be good enough for histopathology. It may be fantastic for IHC, but not for molecular biology workup. So very important to use neutral buffered formalin to avoid either overfixation or underfixation, because so far as the molecular biology workup is concerned, both are equally bad. Acidic fixators, if they are used, which they are especially for bone biopsies, invariably lead to a lot of DNA degradation. And these are really, really compromised samples, which more often than not do not yield good quality DNA, good quality RNA for further workup. Quality of wax, this also has been pointed out, plays a very important role. In our protocols, we do not really use xylene for wax removal. And this one factor we found in our experience has made a huge difference to the quality of the nucleic acid that we get. In our lab, we use ultra clear for wax removal. We use magnetic bead extraction protocol. But for those of you who do not have the extraction bead, the magnetic bead system, an alternate for you guys to use might be, go ahead with QIAGEN gene read protocol, which is manual, and along with that, use Ampere. So that really helps remove out the very, very smaller fragments, the degraded DNA fragments. So you're left with sort of like, the purer quality between 100 to 150 odd base pairs, which one might want to use for further library preparation. Otherwise, as Dr. Neeraj had mentioned, what tends to happen is that when you pool these samples from different kinds of samples, some of which have a good DNA quality and others the compromised one, the smaller ones, they tend to sort of like, hijack off your complete experiment and protocol. So these are certain small things that might help. Yeah, sure. So I'll just skip these because it has already been commented upon. QC, again, very important here to ensure before one goes ahead that the QC data, the QC, both in terms of the loading as well as the histogram here ought to be good. And of course, the analysis is something that has already been spoken about. And very, very important, the lab has to ensure that their Phred score passes muster, because there is no point generating out a report for somatic mutation if your coverage is only about 150, 200. There might be a lot of false negatives that one might have. So, and of course, follow guidelines. There are guidelines, there are updates available of what should be called as a variant, what is the percentage for somatic mutation or for germline, which is important, how exactly one goes about calling it as a variant of significance. So NGS in the right hands is a remarkable tool for patient management, but just like any other technology, any other tool, it is very important that the laboratory that is using it must ensure that we follow, firstly, to begin with, we do a thorough analytical as well as clinical validation. And then for every single assay, every single sample, every time, the QC has to be ensured. And of course, then one can have great results coming out, which would help the clinician, which would help the patient. And the face of molecular diagnostics is changing because there are newer biomarkers, technologies, and algorithms coming. And along with that, we are evolving as well. So thank you so much for your patient hearing.